Welcome to the deep dive. We're here to take that really dense stack of knowledge you're facing and find the quickest path through it.
That's the goal.
And today we are tackling, well, it's a big one, a really fundamental unit in pharmacology, controlling the body's internal wiring, the autonomic nervous system, the ANS.
Foundational is the right word. I mean, the ANS, it's your body's automatic pilot, isn't it? It runs everything you don't consciously manage, your heart rate, digestion, how your pupils react, glands. It's all happening in the background.
Like an orchestra conductor, you said before, just keeping everything humming along.
Exactly. And it does this through this amazing system of checks and balances. You've got the sympathetic nervous system, the SNS, that's your fight or flight mode, high energy.
Metal to the metal.
Right. And then there's the parasympathetic nervous system, the PNS, which handles rest and digest, more relaxed functions. And these two, they're constantly in this kind of push and pull, maintaining balance, homeostasis.
Okay, so our mission today, we need to map out the four big drug classes that let us tweak this balance, right?
Precisely. We have to get clear on the difference between agonists, the drugs that stimulate or mimic the natural signals, and antagonists, which are the blockers, the inhibitors.
For both systems,
Yeah.
SNS and PNS.
For both. If we can nail down these four types, SNS agonists, SNS antagonists, PNS agonists, and PNS antagonists, then understanding why we use them, what problems they cause, and the critical safety stuff for nursing, it all starts to fall into place.
It makes sense. So where do we start? Fight or flight?
Let's start there. Let's flip the switch on the fight or flight system first.
Okay, part one. Messing with the sympathetic nervous system using adrenergic drugs. And first up, adrenergic agonists, chapter 18 stuff.
These are the sympathomimetics.
Sympomimetics, meaning they mimic the sympathetic system.
Exactly. They copy or, boost the effects of your body's own stress chemicals, the endogenous catecholamines.
Like adrenaline, epinephrine.
Yep. Epinephrine, EPI, norepinephrine, NE, and dopamine. Those are the main natural ones.
Yep.
And when we give drugs that act like them, or even give those chemicals themselves as drugs, plus synthetic ones like dobutamine, we're essentially triggering that big fight or flight reaction.
But it's not just one big blanket effect, is it? The book emphasizes receptors.
Absolutely crucial point. The effect depends entirely on which specific receptor the drug hits in the body. It's like different buttons activating different systems.
Okay, so let's map these receptors out. Table 18.1 in the source material really breaks this down. Alpha receptors first.
Right. Let's start with alpha-1 receptors. These are the most common alphas, and they sit on the postsynaptic cells, the actual target tissues the nerve is trying to activate.
Like muscles or glands.
Muscles, glands, blood vessels.
Yeah.
Exactly. And when you stimulate alpha-1, the big effect, the main one, is vasoconstriction. Blood vessels clamp down.
Okay, tightening the vessels. What else?
You also get some CNS stimulation, contraction of smooth muscle in places like the bladder sphincter in the uterus, and interestingly, pupil dilation.
Yeah.
Mydriasis.
Mydriasis.
Yeah.
Wider pupils. Right. So alpha-1 stimulation sounds key for like jacking up blood pressure by squeezing those vessels.
Yeah.
We'll come back to that with pressors, I bet.
We definitely will. Now, moving on to the beta receptors. First, beta-1 receptors. Easiest way to remember. Beta-1, you have one heart.
Ah, clever. So beta-1 is mostly heart stuff.
Primarily heart, yes.
Yeah.
And stimulating beta-1 is all about ramping up cardiac performance. We talk about positive effects because they boost things. Positive chronotropic, that's faster heart rate.
Chrono, like time. Makes sense.
Positive inotropic, that means stronger contractions, more force with each beat. And positive dramatropic, faster electrical conduction through the heart.
So faster, stronger, better conduction. Got it.
And there's one other key beta-1 effect. In the kidneys, it triggers more renin release, which also plays into blood pressure regulation. But the heart effects are the main show.
Okay, so beta-1 cranks up the heart. Why is beta-2 so different then? It seems like they do opposite things sometimes.
It's a beautiful design, really. Beta-2 receptors are found mainly in the smooth muscle of your airways, the bronchioles, and also in arterioles and some organs.
Airways. So lungs.
Primarily lungs, yes. And unlike alpha-1, which causes tightening, beta-2 stimulation causes relaxation. So in the lungs, you get bronchodilation. Airways open up.
Ah, that's why beta-2 agonists are used for asthma, to open the airways.
Exactly that. It also relaxes smooth muscle in the GI tract and uterus. And a really important one, it triggers glycogenolysis.
Glycogenolysis, breaking down stored glucose.
Yes, releasing sugar into the blood. Gives you that quick energy burst you need for, well, fighting or fleeing.
Okay, alpha-1 constricts vessels, beta-1 speeds the heart, beta-2 opens airways and releases sugar. What about those dopamine receptors? They seem special.
They are kind of exclusive, yeah. Dopaminergic receptors are only stimulated by dopamine itself, and their unique thing is causing dilation widening of specific blood vessels.
Which ones?
The ones supplying the kidneys, the gut, mesenteric, the heart, coronary, and the brain, cerebral. So it's a very targeted way to increase blood flow just to those vital organs. Super important in treating certain kinds of shock.
Okay, that receptor map is critical. Now, the source material mentions how these drugs actually work at the synapse. Direct, indirect, mixed acting. Can you break that down simply?
Sure. Think of the receptor like a locked door. The natural neurotransmitter, like norepinephrine, is the original key.
Okay.
A direct-acting drug, like epinephrine, is basically a perfect copy of the key, or maybe a master key. It fits right into the lock of the receptor and opens the door itself. Direct action.
Simple enough. What about indirect?
An indirect-acting drug, like amphetamine.
Mm-hmm.
Well, it doesn't have a key for the door at all. Instead, it goes to the nerve ending nearby, the storage room, and basically forces the release of all the stored original keys, the natural catecholamines. So it causes effect indirectly by flooding the area with the real neurotransmitter.
I see. It causes a release of the natural stuff.
Exactly. And then mixed-acting drugs like ephedrine, they just do both. They have a key that fits the lock, and they trigger the release of more keys from storage. Best of both worlds sometimes.
That analogy helps a lot. Okay, let's zoom in on the clinic now. Vasoactive adrenergics, or pressors. The book really highlights how the dose changes everything with these.
Oh, absolutely. Understanding the dose-dependent effects of dopamine and epinephrine. That's like core critical care knowledge. Life or death stuff. Let's start with dopamine. Table 18.2 is good here.
Right. So at the lowest doses, what are you talking, like 0.5 to 2 mics per kilo per minute?
Yeah, in that range. We call it the low or renal dose. At this low rate, dopamine mainly tickles those special dopaminergic receptors we just talked about.
The ones that dilate specific arteries.
Exactly. You get dilation of the renal and mesenteric arteries. So the goal here isn't usually to raise blood pressure overall, but specifically to improve blood flow to the kidneys, maybe to prevent kidney damage and shock, without drastically changing systemic BP.
Okay. What happens if you crank up the drip rate a bit? Say 2 to 4 mics per kilo, the moderate dose.
Now dopamine starts hitting the beta-1 receptors harder. So you see those positive inotropic effects kick in, stronger heart contractions, better cardiac output.
So this is when you need the heart pump to work better, like in heart failure.
Precisely. It's often the sweet spot if the main issue is pump failure and you want to boost output without causing massive constriction everywhere else.
But what if the patient's blood pressure is still in the basement? You might need to go higher.
If they're profoundly hypotensive, yes. You might push the dose above 4 mics per kilo per minute, entering the high dose range.
And what happens then?
Now, the alpha-1 effects dominate. You get that widespread, powerful vasoconstriction. Blood pressure shoots up. But
There's always a but.
yeah, that intense alpha-1 squeeze can really clamp down on peripheral blood flow. Fingers, toes, skin.
Yeah.
The risk of tissue damage, ischemia, goes way up. It's a trade-off.
Okay. What about epinephrine, the classic code drug? Similar dose-dependent curve.
Similar idea, slightly different profile, because epi hits everything. It's the classic non-selective agonist. At low doses, say 1 to 4 micrograms per minute.
Note, not per kilo for epi, just per minute.
Good catch. Yes, just me jamming. At low doses, the beta effects, beta-1 and beta-2, are more prominent. Stronger heartbeat, faster rate, beta-1, and crucially bronchodilation, beta-2.
Ah, the anaphylaxis effect. Open the airway, support the heart.
Exactly why it's the go-to for anaphylaxis. Life-saving bronchodilation plus cardiac support. But if you need more pressure, you go to high doses, maybe 4 up to 40 milligerman. Then the alpha-1 effects really take over. Intense systemic vasoconstriction. Massive BP increase. This is reserved for profound shock, circulatory collapse.
Wow. These are incredibly potent drugs. High alert is an understatement. Dopamine, epinephrine, norepinephrine, phenylephrine. The safety protocols must be ironclad.
Absolutely non-negotiable. Medication errors here are catastrophic. Take epi concentrations, for example. You used to see ratios like 1.1 thousand to 1.10 thousand.
Yeah, I remember that. Always confusing.
Terribly confusing and deadly. 1.1 thousand is concentrated 1 milligram per milliliter. 1.0 thousand is dilute 0.1 milligml. That's a tenfold difference. Mix them up in a code situation. Disaster.
So the standard now is just mgml.
Yes. Clear concentration labeling, mgml, is the mandate to prevent those errors.
And another safety flag the book raises is the name confusion. Norepinephrine and phenylephrine.
Oh, the sound alikes. It's a huge risk, especially with verbal orders or hurried charting.
Hmm.
Norepinephrine, trade name often Levofed, and phenylephrine, often neosynephrine. They sound similar, but they act differently.
What's the advice?
Always use the generic names. Always clarify. Because mixing up Levofed and neosynephrine in an ICU setting could cause wild, dangerous swings in blood pressure.
Okay, let's talk about a major complication,
Yeah.
extravasation, when the IV leaks.
So that's a tissue emergency. If one of these potent alpha-1 agonists leaks out of the vein and into the surrounding tissue,
What happens?
intense localized vasoconstriction, it cuts off blood supply right there. The tissue becomes ischemic, starves for oxygen, and can die within hours. Necrosis, leading to surgical debridement, skin grafts, even amputation if it's severe and not treated immediately.
So what's the immediate fix? The antidote.
You need to counteract that alpha-1 vasoconstriction. The antidote is an alpha blocker called phentolamine.
Ah, fighting fire with fire, or alpha with alpha blocker.
Exactly. You inject phentolamine subcutaneously in a circle around the infiltrated site. It directly blocks the alpha-1 receptors, forces the vessels back, open vasodilation, and restores blood flow, saving the tissue. Knowing phentolamine is the antidote is key.
One last point on agonists before we switch gears. Older adults, how do they handle these drugs?
It's tricky. Older adults often have less responsive baroreceptors. Those are the sensors that help adjust BP quickly when you change position.
So they're already a bit unstable with BP.
Can be. This makes them extra sensitive to the powerful effects of adrenergic agonists. They can overshoot easily into severe hypertension or get arrhythmias. But paradoxically, that same baroreceptor issue makes them more prone to orthostatic hypotension dizziness when standing up even without these drugs.
So more risk of high BP and low BP.
In a way, yes. It means you have to monitor their vitals, especially orthostatic pressures, incredibly closely, even more so than usual in critical care. Hashtag 1.2, adrenergic-blocking drugs, sympathetics, Chapter 19.
All right, we've hit the gas pedal on the sympathetic system. Now let's slam on the brakes. Chapter 19, adrenergic-blocking drugs, the sympathetics.
Right. Sympathetic means breaking down or blocking the sympathetic system. They inhibit or block SNS stimulation, basically doing the opposite of the agonists we just discussed.
And they're grouped by which receptor they block, alpha or beta.
Exactly. You have alpha blockers, beta blockers, and sometimes drugs that block both, like labetalol or carvedilol.
Let's start with alpha blockers. If alpha-1 agonists cause vasoconstriction.
Then blocking alpha-1 causes vasodilation. The vessels relax, open up, and blood pressure drops.
Makes sense. What else do they do?
They also relax smooth muscle in the bladder neck and prostate. Reduced tone there.
Ah, so that explains their uses. Hypertension because they lower BP.
Yep, drugs like doxazosin, terazosin are used for hypertension.
And benign prostatic hyperplasia, BPH, for prostate issues.
Right. This is where drugs like tamsulosin Flomax, as the common trade name, really shine. They specifically target those alpha-1 receptors in the prostate and bladder neck, relaxing the muscle, easing the urinary obstruction, and improving flow for men with BPH.
It's pretty cool how blocking the same receptor helps two totally different problems.
It really highlights how receptor location dictates the drug's effect. Same mechanism, different tissues, different outcomes.
But alpha blockers come with a big warning sign, don't they? The first dose phenomenon?
Oh, yes. Critically important. The very first time someone takes an alpha blocker, they can have a really sudden, dramatic drop in blood pressure.
Why does that happen?
The body just isn't ready for that sudden, widespread vasodilation. The compensatory mechanisms haven't kicked in yet. It can lead to dizziness, lightheadedness, even fainting syncope.
So what's the crucial advice for patients starting these?
Take the very first dose at bedtime, lying down, to minimize the risk. And always warn them about orthostatic hypotension in general. Get up slowly from sitting or lying down. Dangle feet first. That advice is crucial throughout therapy, not just the first dose.
We mentioned phentolamine again earlier as the antidote for extravasation. That's an alpha blocker, right?
Correct. Phentalamine's specific job is to block alpha-1 receptors to cause vasodilation. That makes it the perfect tool to reverse the dangerous vasoconstriction caused by an extravasated alpha-1 agonist, an alpha blocker fixing an alpha agonist problem.
Okay, moving to beta blockers. Probably one of the most common drug classes out there. The first split is selectivity.
Yes. You have cardioselective beta blockers, which primarily target beta-1 receptors in the heart. Think atenolol, metoprolol.
And non-selective ones?
They block both beta-1 and beta-2 receptors. Propranolol is a classic example. Generally, if the goal is heart-related, cardioselective is preferred to avoid beta-2 side effects.
So what are the main effects of blocking beta-1 in the heart, if stimulating it speeds things up?
Blocking it slows things down. You get decreased heart rate, negative chronotropy, decreased force of contraction, negative inotropy, and slowed electrical conduction negative dermotropy.
Less work for the heart.
Exactly. It reduces the heart's oxygen demand, which is why they're so good for angina, managing heart failure long-term, and controlling certain arrhythmias.
The book calls them cardioprotective after a heart attack. MI. What does that mean?
It's a vital role. See,
Mhm.
after an MI, your body freaks out and releases a flood of stress hormones, catecholamines like epinephrine.
The same ones we talked about stimulating the heart.
The very same. But on a damaged heart, that extra stimulation can be harmful. It increases heart rate, increases oxygen demand on already injured tissue, and raises the risk of dangerous rhythms or more damage.
So beta blockers shield the heart.
Precisely. They block those beta-1 receptors, preventing the circulating catecholamines from overstimulating the damaged heart. It literally protects the heart muscle while it heals.
Makes sense. Now, the big danger zone. Blocking beta-2 receptors with the non-selective beta blockers. What are the risks?
Two huge ones. First, lungs. Remember, beta-2 stimulation causes bronchodilation.
Right. Opens airways.
So blocking beta-2 causes the opposite, bronchoconstriction. The smooth muscle in the airways tightens up.
Which is bad news for.
Anyone with asthma, COPD, or other reactive airway diseases. Giving a non-selective beta blocker like propranolol to an asthma patient could trigger a severe, potentially fatal asthma attack. It's generally a major contraindication.
Okay, lung risk is clear. What's the second big risk with non-selective agents?
It involves blood sugar, specifically in diabetic patients. Beta-2 stimulation normally helps release glucose via glycogenolysis. Blocking beta-2 can impair that process, potentially worsening low blood sugar, hypoglycemia.
But that's not the main danger, is it?
The really dangerous part is that beta blockers, both selective and non-selective to some extent, can mask the warning signs of hypoglycemia.
How so?
Think about the typical signs of low blood sugar: shakiness, nervousness, rapid heartbeat, tachycardia. Those are largely driven by the sympathetic nervous system kicking in. Beta blockers dampen that sympathetic response.
So the patient doesn't feel the warning signs.
Exactly. They might not feel the tremor or the racing heart, so they don't realize their sugar is dropping dangerously low until it's really severe. The only sign that often remains is sweating. It's a major safety concern for diabetics on beta blockers.
Wow, okay. Another huge safety point. The black box warning about stopping beta blockers.
Critically important. You must never stop beta blocker therapy abruptly. Never.
Why not? What happens?
Well, while the patient is on the blocker, their body compensates. The beta receptors become upregulated. They become more numerous and more sensitive, trying harder to catch any available signal.
Okay.
If you suddenly remove the blocker, all those supersensitive receptors are suddenly exposed to the body's normal circulating catecholamines. The result is an exaggerated, unopposed sympathetic surge,
Beating too.
rebound hypertension, worsening angina, potentially triggering a heart attack or dangerous arrhythmias. Patients must be weaned off slowly, usually over 1 to 2 weeks, under supervision.
Got it. Taper off slowly. And one last practical point. Metoprolol dosing errors.
Yes, a common source of confusion and errors. Metoprolol comes in two main forms: metoprolol succinate and metoprolol tartrate.
What's the difference?
Succinate, often Toprol XL, is the extended release ER version, usually taken once a day. Tartrate, often low pressor, is the immediate release IR version, typically taken twice a day.
And the risk is mixing them up.
Big risk. If you accidentally give the IR form when the ER was intended, you could get a sudden large dose effect, causing severe bradycardia or hypotension. If you give the ER when IR was ordered twice daily, the patient might be underdosed for part of the day.
So double check the specific formulation.
Always. Verify metoprolol succinate versus tartrate and confirm the dosing schedule matches the formulation. Obsessive diligence is required.
Okay, we've thoroughly explored the fight-or-flight system and its drugs. Time to shift gears completely. Let's dive into the other side. The rest and digest system, the parasympathetic nervous system, PNS. Chapter 20, cholinergic drugs.
Right. Now we're dealing with the main neurotransmitter of the PNS, which is acetylcholine, or ACE. And the drugs that mimic it are cholinergic agonists, also called parasympathomimetics.
Mimicking the rest and digest functions. What are the key receptors here? Not alpha and beta anymore, right?
Correct. For the cholinergic system, we have two main types: nicotinic and muscarinic receptors.
Nicotinic and muscarinic. Where are they, and which ones do we usually target with these drugs?
Nicotinic receptors are found in the ganglia of both the SNS and PNS and at the neuromuscular junction. Muscarinic receptors are located postsynaptically on the target organs of the PNS. Think smooth muscle, cardiac muscle, glands.
So where do we want the action?
For most therapeutic effects we're discussing here, we're primarily interested in stimulating the muscarinic receptors. That's what produces the classic rest and digest effects.
And what are those effects? If adrenergic agonists were about speeding up and drawing out, these must be the opposite.
Pretty much the exact opposite. Think increased secretions, increased GI and GU motility, slowed heart rate, pupillary constriction. Everything gets, well, wetter and slower.
Which brings us to that very memorable, slightly gross mnemonic for the side effects and toxicity, SL-LUDGE.
Ah, yes, SL-LUDE. It perfectly captures what happens when you have too much cholinergic stimulation. It stands for salivation,
Drooling,
lacrimation,
tearing up,
urinary incontinence,
voting themselves.
diarrhea,
Yeah,
GI cramps,
stomach upset,
and emesis.
vomiting. Basically, fluids leaking from everywhere and
Yeah.
hyperactive bowels and bladder.
That's the picture. If you see SLEDGE symptoms developing, you need to think excessive cholinergic activity, potentially a crisis.
Okay. Like the adrenergics, these cholinergic agonists also have direct and indirect ways of working.
They do. The direct-acting cholinergic agonists, like bifenacil, bind directly to the muscarinic receptors and activate them. Simple enough?
And the indirect ones.
The indirect-acting agonists are actually enzyme inhibitors. They're called cholinesterase inhibitors, or ACE inhibitors.
Cholinesterase, that's the enzyme that breaks down acetylcholine, right?
Exactly. Normally, ACE gets released, does its job at the receptor, and then acetylcholinesterase quickly cleans it up, breaks it down to stop the signal.
So these drugs stop the cleanup crew.
Precisely. Drugs like donepezil or pyridostigmine inhibit acetylcholinesterase. By blocking the enzyme, they allow the naturally released AC to hang around in the synapse longer and stimulate the receptors more intensely. More AH effect? Indirectly.
Clever. Let's look at uses. Bifenacil, the direct one, what's it used for?
Bifenacil's main gig is treating non-obstructive urinary retention, often seen after surgery or childbirth when the bladder is sluggish.
How does it help?
It stimulates the muscarinic receptors on the bladder. Increasing the muscle tone and motility makes the bladder contract more forcefully while also relaxing the bladder sphincter. Helps the patient empty their bladder.
Okay, makes sense. Increasing the U in SLDGE, but therapeutically. Now, the indirect ones, the enzyme inhibitors, they treat some chronic conditions.
Yes, two main ones mentioned prominently: myasthenia gravis, MG, and Alzheimer's disease, AD.
How do they help in myasthenia gravis?
In MG, the issue is impaired transmission at the neuromuscular junction. There isn't enough ACE effect to properly stimulate muscle contraction, leading to weakness. Indirect agents like pyridostigmine increase the amount of ACE available at that junction, improving muscle strength.
The source material also mentions edrophonium.
Yeah, edrophonium tensilon is a very short-acting inhibitor. It used to be used more for diagnosing MG. Giving a dose would cause a temporary dramatic improvement in strength if the person had MG. It could also help differentiate between an MG crisis, too little drug, and a cholinergic crisis, too much drug.
Okay. And the other big use, Alzheimer's disease.
Right. In AD, there's a loss of cholinergic neurons in the brain, leading to lower ACE levels, which contributes to memory and cognitive decline. Cholinesterase inhibitors like donepezil, Aricept, work by increasing the available ACE in the brain.
Does it cure Alzheimer's?
No, unfortunately not. It's purely symptomatic relief. It can help improve memory, attention, and daily function for a time, maybe slow the progression of symptoms, but it doesn't stop the underlying disease process.
The unit mentions a couple of other AD drugs briefly, memantine and aducanumab. Are they cholinergic?
No, and it's important to distinguish them. Memantine works on a different neurotransmitter system, entirely glutamate, acting as an NMDA antagonist. It's often used with drugs like donepezil. Aducanumab is one of the newer, very expensive drugs. It's a monoclonal antibody designed to target the amyloid plaques in the brain. A totally different approach. So while they're for AD, they aren't cholinergic drugs.
Good clarification. Now back to the cholinergic agonist. If SLUDGE represents the side effects, what happens in a severe overdose? Cholinergic crisis.
Yeah, that's SLEDGE dialed up to 11, plus muscle weakness or paralysis, potentially respiratory failure because the diaphragm gets weak, and cardiovascular collapse, shock, cardiac arrest. It's a full-blown medical emergency.
And the antidote, if too much rest and digest is the problem.
You need to block it immediately. The antidote is atropine. Atropine is a powerful cholinergic antagonist that blocks the muscarinic receptors, reversing the excessive stimulation. Sometimes you might also need supportive care like epinephrine to manage the severe cardiovascular effect.
Atropine. Got it. Okay, quick nursing implementation point for myasthenia gravis patients taking pyridostigmine.
Timing is absolutely critical Because the drug boosts muscle strength temporarily, you want that peak effect to coincide with meals to help with chewing and swallowing.
So give it when?
Give the oral dose about 30 minutes before meals. That helps optimize their strength for eating and reduces the risk of choking or aspiration.
Good practical tip. And for the Alzheimer's drugs like Donepezil.
Remember, it's symptomatic, not curative. But also, these drugs can cause dizziness, fatigue, sometimes fainting due to slowed heart rate. So safety is huge. Fall precautions, monitoring for bradycardia and hypotension are really important. Hashtag 2.2 cholinergic-blocking drugs. Parasympathetics, anticholinergics, Chapter 21.
All right, we stimulated rest and digest. Now let's block it. Chapter 21, cholinergic-blocking drugs, also called anticholinergics or parasympathetics.
Exactly. These drugs do the opposite of the agonists. They block the action of acetylcholine, specifically at the muscarinic receptors.
So if they block the rest and digest signals,
Then the fight-or-flight system, the SNS, is left unopposed. Its influence becomes dominant. So the effects you see often mimic sympathetic stimulation, drying things out, speeding things up.
the opposite of SLUGE. And there's another famous mnemonic for these effects, right? The descriptive one.
Yes, the classic rhyme describing anticholinergic toxicity or side effects. HOT is a hair,
Why hot?
because they decrease sweating, impairing the body's ability to cool down. DRY is a bone.
Makes sense. Decreased secretions, dry mouth, dry eyes.
Yep, decreased saliva, tears, GI secretions.
Yeah.
Blind as a bat,
You too.
pupil dilation mydriasis again, and also paralysis of accommodation, cycloplegia, causing blurred vision. Red as a beet.
From vasodilation.
Sometimes, yeah, peripheral vasodilation can cause flushing. And finally, MAD as a hatter.
Meaning.
CNS effects.
Mm.
Confusion, agitation, delirium, hallucinations, especially in older adults or with high doses.
Okay, so hot, dry, blind, red, mad. That paints a pretty clear picture. Let's list the key physiological effects again.
Okay, increased heart rate, decreased GI motility, big risk for constipation, even paralytic ileus, decreased bladder contraction leading to urinary retention, and that really important one, decreased sweating, raising the risk of hyperthermia, also increased intraocular pressure due to the pupil dilation.
Let's look at uses. Atropine, the prototype anticholinergic. We mentioned it as the antidote for cholinergic crisis, but it has other big uses.
Absolutely. In emergency medicine, atropine is crucial for treating symptomatic bradycardia when the heart rate is dangerously slow and causing symptoms.
How does it work there?
It blocks the vagus nerve's inhibitory effect on the heart. The vagus nerve is part of the PNS, constantly putting the brakes on the heart rate. Atropine blocks those brakes, allowing the heart rate to increase. It's also used in cardiac arrest protocols for asystole, though its effectiveness there is debated more now.
Okay. What about GI and GU uses? We see these drugs a lot for bowel and bladder issues.
Yeah, for GI, a drug like dicyclamine can be used for irritable bowel syndrome, IBS, to reduce cramping and excessive motility. Decreases those painful spasms.
And for the bladder. Overactive bladder, OAB, seems like a big target.
Definitely. Drugs like oxybutynin, ditropan, and tolterodine ditrol are mainstays for OAB. They work by relaxing the detrusor muscle, the main muscle of the bladder wall, which reduces that feeling of urgency and frequency.
So they calm the bladder down.
Right. But the flip side is, by relaxing the bladder and potentially tightening the sphincter, they can also cause significant urinary retention, especially problematic in men who already have BPH.
Always a trade-off. What about preoperatively? Sometimes patients get these before surgery?
Yes, drugs like glycopyrrolate or atropine might be given pre-op specifically to decrease saliva and respiratory secretions, makes anesthesia safer, reduces aspiration risk.
And scopolamine. That seems to have a unique use.
Scopolamine is probably the most potent antimuscarinic agent we have, and its main niche is preventing motion sickness.
How's it used?
Most commonly as a transdermal patch worn behind the ear. You apply it a few hours before travel, and it can work for up to 3 days. Very effective for boats, cars, planes, if you're prone to motion sickness.
Okay. Safety concerns. Who is most at risk with anticholinergics?
Older adults are particularly vulnerable. They're much more sensitive to the CNS side effects, the confusion, delirium, the mad as a hatter stuff.
Why is that?
They often have lower baseline cholinergic activity, so blocking what little they have has a bigger impact. Plus, they're already at higher risk for things like constipation and urinary retention, which these drugs make much worse. Careful dosing and monitoring are essential.
And we have to reemphasize that hyperthermia risk.
Absolutely critical, especially with summer heat or exertion. Because these drugs knock out the sweating mechanism, the body can't cool itself effectively. Patients must be educated to avoid overheating, stay hydrated, and avoid strenuous activity in hot weather. Heat stroke is a real and potentially fatal risk.
And contraindications, who absolutely shouldn't get these?
Key contraindications include known drug allergy, angle closure glaucoma, because dilating the pupil can dangerously increase eye pressure, myasthenia gravis, any kind of GI or GU tract obstruction, like paralytic ileus or severe BPH, because the drugs would worsen it.
Hmm. Okay, we made it through all four major drug classes across two complex chapters, stimulating and blocking both the SNS and the PNS. Now, the real power comes from seeing how it all fits together, right? Seeing the patterns.
Exactly. That's the synthesis part. Instead of four separate lists of drugs and effects, you start seeing the underlying principles. The ANS is about balance homeostasis. These drugs are just tools we use to deliberately tip that balance one way or the other.
And there's a kind of symmetry to it.
Definitely. Think about it. Stimulating the SNS with an adrenergic agonist often produces similar effects to blocking the PNS with an anticholinergic. Both can lead to increased heart rate, dry mouth, dilated pupils. The SNS is unopposed in both scenarios.
Okay, that makes sense. And the flip side.
Blocking the SNS with an adrenergic blocker, especially beta blockers, often looks similar to stimulating the PNS with a cholinergic agonist. Both tend to decrease heart rate, increase secretions or motility, though blockers might just reduce drive. The PNS influence becomes more dominant.
So knowing if it's an agonist or antagonist and which system, SNS or PNS, it targets, that predicts the main effects.
It's the fundamental key. If you understand that mechanism, agonist versus antagonist, adrenergic versus cholinergic, you can predict the therapeutic uses, anticipate the major side effects, like SLDGE versus hot-dry blind, and figure out the crucial nursing implications.
Let's talk about one implication that cuts across all four classes, vital signs, the vitals nexus, as you called it.
Yes, because both the SNS and PNS have profound control over the heart and blood vessels, every single one of these drug classes significantly impacts heart rate and blood pressure.
So no matter which of the four types of drugs a patient is on.
Consistent, careful monitoring of vital signs, pulse, blood pressure, and definitely checking for orthostatic hypotension is arguably the single highest safety priority for the nurse across this entire unit. It's non-negotiable.
Can we quickly recap the expected vital sign patterns? If heart rate or BP is going UP, which drug classes are likely involved?
You'd suspect either an adrenergic agonist, stimulating beta-1 for heart rate, alpha-1 for BP, or a cholinergic blocker, anticholinergic like atropine, which removes the PNS brake on the heart.
Okay. And if heart rate or BP is going down?
Then you're likely looking at an adrenergic blocker, beta blocker slowing the heart, alpha blockers lowering BP via vasodilation, or a cholinergic agonist like bethanical, or the side effects of donepezil directly stimulating the PNS brake.
That pattern recognition is powerful. Let's apply the same contrasting logic to the GI and GU systems, motility, flow, secretions.
Okay. Generally speaking, the agonists tend to get things moving or flowing out. Cholinergic agonists, like bethanical, clearly increase GI motility and bladder contraction. They make you go.
They induce SLUDG effects, essentially.
Right. Adrenergic agonists have more mixed effects here depending on the receptor, but don't typically cause the widespread slowing that blockers do.
So the blockers slow things down or, interestingly, sometimes relax things to improve flow.
Exactly. Cholinergic blockers, the anticholinergics like oxybutynin, definitely slow things down. They decrease GI motility, causing constipation, and decrease bladder contraction, causing urinary retention. They're drying and slowing.
But alpha blockers, an adrenergic blocker.
That's the exception that proves the rule about knowing the specific receptor. Alpha blockers like tamsulosin relax the smooth muscle of the prostate and bladder neck. So even though they are blockers, their therapeutic effect in BPH is to increase urinary flow by reducing obstruction. But they still carry the risk of hypotension from blocking alpha-1 on blood vessels.
So you absolutely have to know the specific receptor and tissue involved.
You really do. It dictates the outcome.
Okay, let's crystallize this. Pull together the absolutely essential recurring safety interventions and nursing actions from across these chapters, the must-dos.
Right. The core safety checklist for ANS drugs.
Antidote availability, know them and know where they are. Atropine for cholinergic crisis. Phentolamine for adrenergic agonist extravasation, especially crucial for high-alert infusions.
Got it. Antidote's ready.
Number 2, position changes. Slow and steady wins the race. Patients on alpha blockers, anticholinergics, or even pressors need education on changing positions slowly to prevent falls from orthostatic hypotension. Dangling feet is key.
Okay, slow position changes.
Number 3, adherence and discontinuation. Hammer home that black box warning. Never stop beta blockers, or other blockers generally, abruptly. Rebound crisis is real and dangerous. Tapering is mandatory.
Don't stop suddenly. Check.
Number 4, dosing and formulation accuracy. Be paranoid about it. Double check epinephrine concentrations, mg/ml, not ratios. Verify metoprolol, succinate versus tartrate, and the schedule. These errors kill.
Meticulous checking. Yep.
Number 5, integrate non-pharmacologic care. Drugs aren't the whole story. For anticholinergic dry mouth, advise sips of water, hard candy, meticulous oral care. For Alzheimer's patients on Dunpeacil, encourage routines, safety measures, maybe physical activity like walking, which also helps. For constipation risk, fluids and fiber. For orthostatic risk, support hose maybe. These complement the drug therapies.
Right, the simple stuff matters.
Hugely. And finally, number 6, targeted monitoring. Beyond vitals, watch for specific warning signs. Daily weights for patients on blockers looking for fluid retention or worsening heart failure. Monitor bowel function closely with anticholinergics or opioids. Assess for CNS changes, confusion, delirium, especially in older adults on anticholinergics. Catching problems early is key.
That's a solid synthesis. It really shows how understanding the system ties all the nursing actions together. It's quite amazing the power we have to manipulate these involuntary systems with such specific drugs.
It is incredible, and the complexity demands that deep understanding. You can't just memorize lists. You have to grasp the mechanism.
So the final takeaway, the provocative thought.
I think the ultimate insight from this whole unit is this. If you're ever unsure about an ANS drug, what it does, why it's used, what to watch for, go back to the basics. Ask, 1, is it an agonist or an antagonist? Stimulating or blocking. 2, is it working on the adrenergic system, alpha-beta receptors, or the cholinergic system, muscarinic receptors? Once you nail down that fundamental mechanism of action, everything else the therapeutic uses, the predictable adverse effects, SLUDGE or hot drape line red med, the vital sign changes, the essential nursing priorities it all logically follows, that mechanism is the Rosetta Stone for this entire area of pharmacology. Master that, and you've mastered the core of controlling the body's internal wiring.
Understand the mechanism, unlock the rest. A fantastic way to wrap up this deep dive into the autonomic nervous system pharmacology. Thank you so much for breaking down such a complex topic so clearly.
My pleasure. It's crucial stuff to get right.
Absolutely. Thanks for joining us on the deep dive. We'll see you next time.